Good morning. I'm Mark McClellan. I'm from Duke University in the United States. We have Duke Margolis Center for Health Policy. On behalf of the conference organizers, who I'd like to thank, I'd like to welcome all of you to this morning's session on accountable care, pathways for designing and implementing innovations for high-value health care. I'm going to be joined in just a moment by several other panelists for this discussion. As you all know, a lot of interest at WISH and a lot of your work around the world is focused on finding new and better ways to deliver care, especially for vulnerable populations, taking advantage of new technologies like digital health and AI, new approaches to delivering care based on teams, new ways of integrating social and other services that can make a bigger impact on health outcomes. All of this means a very different way forward for healthcare than the way it has traditionally been organized. And those changes can be very challenging to actually achieve higher value care. Fortunately, there is growing experience around the world with methods to bring together new innovations in care, new structures and organizations for delivering it, and the policies to support those changes. We've talked about this in the context of WISH previous reports and meetings in terms of accountable care, and I'll talk a little bit more about the definition of accountable care in just a minute. But the key point is not the definition. The key point is success, speed, and efficiency on what can be a very challenging journey. Many refer to it as a marathon or an ongoing process of improvement. With growing experience around the world in approaches to high-value care and care transformation, we wanted to use this time today to take stock of where we are, to hear about some of the experiences around the world, and to exchange ideas about how we can make more rapid progress. Now, WISH is a conference, a summit, an ongoing effort with lots of things going on at the same time. We appreciate you being here. I would encourage you to take advantage of some of the complementary sessions that deal with issues that relate to progress on accountable care. One of those is going on right now, so you can't be in two places at once. I guess innovation is working on that too. But the public-private collaboration session is highlighting a lot of ideas for how to bring valuable new approaches to care into healthcare systems by relying on innovative mechanisms in the private sector. So some of our ideas resonate there, and you all have perhaps participated in sessions on care redesign, sessions on moving towards more person-focused care and adoption of innovations in other parts of WISH. So we're going to try to complement that here. First, I'd like to invite up to the stage the panelists who will be joining us for this session. And in that regard, I'm very pleased to introduce Dr. Samia Ahmad Al-Abdullah, who's the Senior Consultant for Family Medicine and Executive Director of Operations for the Primary Healthcare Corporation here in Qatar, where she has been involved in implementing reforms that focus on a transformational approach to primary care and making it a more extensive part of the Qatari healthcare system. I'd also like to ask the Honorable Michael Armitage to come up to the stage too. Dr. Armitage is an advisor to the Minister for the Ministry of the Public Health Office here in Qatar as well. And we were expecting to be joined by Dr. Ashutosh Raghuvanshi, who is Vice Chairman, Managing Director, and Group CEO at Narayana Health, but we understand he's had some complications in joining us today. I also want to emphasize that this is a workshop session, and that means all of you are effectively panelists as well. Looking around the room, I see a lot of people with experience in the move towards accountable care and high-value healthcare systems, so we'll be calling on you all to participate in this discussion as well. To get us started, I'm just going to provide a little bit of background on the approach of accountable care for healthcare transformation. For those of you who got the two-page background document for the session, that's a good reference. There are other references available through WISH as well. I see Waleed moving quickly to make those copies available. So this is what we call just-in-time healthcare transformation. Don't worry about reading all the details of the slide. The important point here is the framework of accountable care emphasizes doing several things at the same time. First of all, recognizing that healthcare innovations that improve care pathways for patients that lead to better outcomes and lower costs are the core of getting to higher value, better outcomes, better results in healthcare systems. But for those innovations to succeed in a real-world context for a healthcare organization, other considerations are also important. That includes healthcare organizational capabilities, such as being able to track patients longitudinally, having a healthcare organization that is focused on people and not just delivering excellence in services, and other key capabilities around financial support for longitudinal patient management, and the ability to implement end-to-end and support and collaborate on new care pathway models. To support these changes in healthcare organizations, accountable care policies matter. These are policies that are not focused on just improving access to specific services, but first and foremost on population. So it's a population, not a service focus in policies, and that means identifying, as a policymaker, important goals for health improvements, or perhaps cost reductions, or perhaps getting more value out of the limited health resources that are available to achieve measurable improvements in outcomes and other meaningful results experience, the triple aim for a population of patients. And then recognizing that there are important supporting policies to make those changes happen, like providing data and feedbacks to support continuous improvement, since these improvements in healthcare system do not happen overnight, like providing learning and support for how healthcare organizations can succeed in these new approaches. And the broader health policy environment matters too. How health professionals are regulated, the kinds of information provided to the broader public to engage them in healthcare reform goals, a broader range of considerations as well. All can help lead to successful delivery transformation. And a key point in this is this shift from individual services and healthcare policies that typically have focused on supply, building a clinic, paying for a hospital, paying for a clinical department. Important as all of that is, to healthcare policies that are focused on the experiences of people from end to end in their healthcare journey, filling in gaps, identifying innovations that can help make those pathways work more efficiently, making that a central focus, not an add-on to traditional healthcare policies. In doing this, we've thought about and worked with many organizations around the world that consider several kinds of changes at the same time. First of all is the focus on delivery innovations at the bottom right of the chart in front of you. What are the sets of changes in care delivery that would make for a better care experience for patients? But making those changes sustainable requires attention to organizational capabilities. If organizations have historically been organized around specific services, not following up with patients after they leave the clinic, or even better, not actively reaching out to patients who are at risk and engaging them in care, and supporting financing models for these types of care. In many places around the world that have relied on fee-for-service payments for admissions or office visits, there can be underinvestment in steps to support care teams and care coordination that can keep patients out of the hospital and avoid traditional medical expenses. And again, other types of policies matter as well. At WISH, there has been, over these past 5 years, attention for using this forum to help make progress in making these systematic transformations in healthcare systems, including developing tools for assessment and capacity building, something that we work on a lot in our program at Duke. Implementation support, it is hard to change healthcare systems, and then learning networks, as more systems around the world are aiming to make transformational changes like these, an exchange of ideas and help in making progress by learning from the experience of others is increasingly feasible. I would just emphasize before wrapping up this introduction that progress is typically incremental, but occurs in each of these directions. You'll hear today about steps that have been taken to identify an innovative approach to patient care pathways for chronic diseases and for other types of patients. Not all of those steps can be implemented at the same time, but it is very important to have an overall strategy in mind and then a pathway for implementation. Similarly, organizations don't change overnight either, but attention to changes in a culture from a focus on service excellence to a focus on patient longitudinal care excellence, reorganization to build in additional capabilities to help support patients longitudinally, reallocating IT resources. All of that can happen over time as part of these reform efforts. And similarly with identifying payment supports. In many countries, these models involve a shift away from fee-for-service or payments in particular silos, a hospital silo, a primary services silo, a specialty services silo, to more integrated or shared resources to support coordinated longitudinal care. It doesn't mean that one organization has to do all of these services, but it does mean resources that are aligned with people and the supports that they need to get innovative care. We have, in previous WISH reports, described some case studies of implementing these models. One, for example, just to show that this can happen in just about any healthcare setting, was in rural Nepal. Duncan Maru, others who have been involved with Possible Health, took a different approach to providing access to primary care in a very low-cost care setting with very limited resources. Instead of a traditional hospital and a traditional clinic, this model is based on a hub-and-spoke way of delivering primary care that relies on community health workers, data support systems, and reaching out to people in the community, financed in a different way, not by paying for a clinic, not by paying for office visits, but by paying a sort of per member per month fee for this organization that is accountable for delivering primary care in a rural setting, is accountable for results like improving access to primary care services, treating chronic diseases, enabling women who are pregnant to give birth in safer institutional settings. The Smart Diabetes Clinic in Qatar, I'm going to turn to Dr. Samia to describe later, but I would emphasize here that this was a program that started incrementally in a way, not incrementally from the standpoint of wanting to focus on patients. It had an end-to-end model in mind for the way that Qatar wanted diabetes care to be delivered, more prevention orientation with more patient engagement, but that program has since expanded to cover a broader range of primary care and chronic care management services. So specialized care can also go into this category. Narayana Health in India, instead of being organized around a fee-for-service model, instead had an all-inclusive, privately paid model for delivering intensive services, including cardiovascular procedures, and now expanding out to other types of specialized care. It's an all-in model of payment to encourage an all-in integrated model of delivery of specialized care, which made possible a whole set of innovations that focus on patients that may have been much more difficult if only certain fee-for-service types of activities were paid for, rather than enabling the organization to be designed and to implement innovations with a single-minded focus on getting the best outcomes at the lowest cost for patients with specialized care needs. So you just heard a summary from Narayana, since he cannot be with us this morning, but I'm happy to provide more details there too. A third type of incremental approach to implementing accountable care has focused on whole populations, like in the Gesundes Kinderspital case study in Germany. This organization took on full accountability for total cost of care for patients and for improving the outcomes for their patient population. That reform enabled them to make investments and support innovations in longitudinal care, care coordination, targeting patients to the right specialists, improving patient follow-up that would not have been feasible under a more fragmented care and payment model. I want to emphasize that to deliver integrated care, an organization does not have to be fully integrated. In the United States, some of the important care integrators that are doing these population-based management programs are primary care groups. But they're primary care groups that have developed the organizational structure, data supports, and team-based approaches to care to be able to integrate services with specialized care providers that are often being paid under new alternative payment models like the one that I described in India. So a lot of countries are implementing policy reforms to support these kinds of care reforms. So the 2018 to 2022 National Health Strategy in Qatar, hopefully Dr. Sami, you can touch on that and how it supports the efforts here. India is in the process of implementing a national health insurance system. Given the financial constraints that India and many other countries face, finding ways to work with private innovator organizations like Narayana Health may be a path towards achieving universal health care goals by relying on private sector organizations with oversight and accountability for achieving better population outcomes at a lower cost. And again, for those of you who are interested in those kinds of public-private collaborations, we are also talking about that in the report that I helped support that's going on now at the same time. Please read that report. Don't leave the room. So with that context, I'd like to turn to, well, just a few more points that I've largely already covered. In this strategy, from the standpoint of a policymaker, is very important to engage the population, the public, and the provider community in why we're making these changes. And front and center is improving those care pathways and care experiences for patients. In every country that we've worked with, there have been high priority opportunities where traditional ways of delivering care are not getting the job done as well as people would like, and innovations that could change it are very hard to adopt in the current structure of care organization and financing. Supporting this is a shift towards a patient or a person focus in regulatory policies and the infrastructure that supports policy, so away from, again, just thinking about silos of care, and at least in part designing policies around people and connecting these different silos and encouraging innovative approaches to achieving the outcomes, even if that's not what has been paid for or the way that care has been regulated in the past. Supporting these incremental improvements in organizational capacity and aligning financial supports round out the approach to implementing these reforms. So that's some context based on the experiences at WISH and in many countries who have participated in this WISH collaboration with us at Duke over the years. I would now like to turn to Dr. Samia to talk about the experience that Qatar has had in moving to smart screening and management and expanding a fundamental vision from an incremental program to a much broader set of reforms.
Assalamu alaikum. Thank you, Mark, for introducing. And I think probably we can talk about our experience here in Qatar. Since WISH 2016, I think we move a lot. Sorry, is this one? So if we can just begin that the accountable care initiative was started in Al Wakra Health Centers. What was at that time, 2016, was specific for diabetes. And why diabetes? Because you know diabetes has a much more economic burden, especially in Qatar and Middle East. And that was showcased in WISH 2016. And over the past 2 years, a significant progress has continued. And so we move forward from January 2016, started in Al Abeeb Health Centers. The diabetes care was expanded to a fully comprehensive primary care-based screening program for both physical and mental well-being, and we get 3 objectives in our mind to achieve. We introduced a preventative screening for common chronic, metabolic, mental, hematological, and cardiovascular illnesses to support the effort to identify any healthcare needs for early diagnosis and treatment. And you know all that we focus on those chronic disease as we are having aging populations. A lot of demand here for a chronic disease here in Qatar and probably in the Middle East. So the second objective, we have to identify any behavioral and risk factor for those chronic disease that the patient is exposed to, which can then be managed by the patient family medicine team in PHCC. Third objective, to act as a gateway into a full range of primary healthcare services on offer at PHCC and support the population of Qatar to take a step to maintain and improve their health. So what we did actually, we have we call patients, approximately 48,000 patients was called. Out of those 48,000, we get invite 29,000 patients to this screening. So, and out of those 29,000, we get only 9,062 screened. And plus those 9,000, we get some opportunistic screening if somebody is walking to the health centers. And so we find this is the time and opportunity to screen, especially those high risk factors. So out of those 9,000, we screen them. 65% of them was female and 35 male, and age 18 to 39 was 50%, and the second 50% was age 40 plus. And just I have to, it's my pleasure to say that now smart clinic or services, it is in all PHCC at 26 health centers. So now we have a full comprehensive smart in all PHCC centers. So this is here we have to discuss some of the outcome and the results we find. We find among those 9,000 that 12% are diabetic patients. 12%, so imagine how it's the absolute numbers, more than 1,000 maybe. And if 24% are pre-diabetic, and those is our focus. If we just think of those, how many percentage we have of 24% are pre-diabetic, and within a few years they can become, unless we have to do some intervention, they become, they can progress to have diabetes with all these complications and disease management, and might cause another burden in the health system unless we have to do something. So here is we are focused in our population health that we can prevent the progression of those diabetic patients. Here, another finding was interesting also, that we have 45% of those patients are obese. And this go actually with our international figures that obesity is increasing and alarming condition in worldwide. 33% are overweight, and 8% is having high cholesterol, 26% having high blood pressures, and 14% of those are smokers. So we can see that all these figures, all this probably need some sort of interventions, and we have to focus on those kind of patients, and we have to do something with our lifestyle modifications or some sort of policy, probably some sort of building capacity in PHCC, so at least we can prevent further progression of those risk factors. Out of those, we find them, those results, the clinical outcome, we find that some sort of things what's happened in the PHCC, that we can link those patients to our services we are offering in PHCC. Like, for example, we refer 20% of those to our dietitians. So whenever we find a candidate that can benefit from our dietitian service, we link them to our services, and 17% of those patients, we refer them to our health educators. 5% we refer them or link them actually to our wellness services, and probably all of you know that we have 5 wellness centers in PHCC, and they are offering services like swimming pools, exercise and gyms, and lifestyle clinic modifications. So these kind of things probably by over time can prevent further progression of a chronic disease, especially that the burden of those chronic disease is increasing time to time. We find that we have, all of you know, we have a cancer initiative for breast and colon cancers. When we find a good candidate of those patients, we link them to our screening services. So 17% of those, we screen them in the SMART, we link them to our cancer screening services. And 2% we refer them to our psychology support clinic, and you know that we have an initiative, mental health clinic in the PHCC. It's a joint collaboration between PHCC and our colleague in secondary care in HMC. We have, with support from both organizations, we develop our psychology support clinic in 4 health centers, and we are going to open the 5th one. So any patient we found them that are, and actually we find I can say that more than 1,000, we discover that they have mild to moderate depression or anxiety. So we refer most of them to this psychology support clinic, and then if they need further follow-up, we can refer them to our colleague in HMC. I'm proud to say that we have almost like 92 patients of our customers, we get it from our some survey, are satisfied with our service in the SMART clinic. And those 92, 100% of them, they recommend this service to be introduced to their families or a friend. And this is from a survey how we did it in the 26 health centers, but we are continuing to do the survey for more and more patients. So, of course, as this pilot is running and launched in 26 health centers, we have a lot of challenges, and also at the same time we have a lot of opportunities. So the main challenge is that Qatar is, the population in Qatar is diverse, it's transient, which will present an opportunity for a value-based care implementations. We have targeted invitation to SMART for Qatari population is in place, but this will be extended for non-Qatari and long-term residents in Qatar's probably 35 years old or above with the 2 or more risk factors in Q3 or Q4 in Qatar's. And of course, we have to build our capacity to accommodate such more numbers of patients or persons that will see them in the primary care. And you know that we should be ready, because it just, population of Qatar, most of them are non-Qatari. So unless we are sure what we are doing for Qatari, then we can extend it for non-Qatari populations. One of the challenges, it's really, we talk about it many times, the no-show rate. And it has been shown that it is high. particularly for the initial screening assessment. We divide this smart screening to 2 visits. The first, after we invite the patient, the first visit is actually it's done by our colleague nursing, and this is the time that we empower our nursing that to be part of this to take care of the patients. So our nurses do an assessment for those patients. They take the personal medical history, they take mental history and family history and social history, and do a lot of screening lab test. So we found that the no-show rate in this initial visit was 44%. However, after the initial visit, the subsequent visit, the consultations time, the consultation visit with the physicians on the second time after we did all the screening tests show that the no-show is dropped to 26%. So this means that the patient recognize now the benefit of this service, and it might, deliver this message to the community, so we can promote this service to accommodate more patients to come to our screening service. Of course, there is an opportunities. We have to continue to track patient outcome over times. We have now probably a good data about our patients, how much we have diabetic and hypertensive, high cholesterols, smokers, mental health. So we know now our patients. We know demographically how much, and probably we need to dig more about developing our data. So we have to continue to promote and raise health awareness with our partners within the communities. We have to continue also to collaborate with our colleague in HMC peoples and the secondary care and other stakeholders. We have to introduce innovation in care, to embrace technology to support at least to support, because sometimes you cannot accommodate all the patients. So how we think of different type of modalities like e-consultations, and I think this is the futures, and we have to do more in this way. We have to continue to strengthen primary care through workforce development and empowerment. And of course, I think we all agree about we have to continue to work on coordinated and integrated care and collaborative working across the health system for better patient outcome. Thank you.
Thank you, Dr. Thank you for that great summary of the journey that PHCC has been on in this path towards accountable, really person-focused and increasingly comprehensive primary care. I see a number of your colleagues here today. I know it's been a lot of work. I appreciate your frankness about the metrics that you're tracking. As you say, it's not possible to implement these systems perfectly right away, but you've got the data and the feedback to keep improving. And I think your net promoter scores are up there with Apple, something very, very high. Dr. Armitage, I'd like to turn to you for some comments about this emphasis on person-centered, value-based healthcare in Qatar. Where do you go from here?
Thank you, Mark, and thank you to the organisers for inviting me to discuss this extraordinarily important topic that Qatar is dealing with, but we can be better. Can I ask you, if you work in the Qatari health system, can you put your hand up? Oh, that's great. Fantastic. You've all got tasks at the end of this. A long time ago, I was a member of Parliament and I was a Minister for Health, and I know that the general view of politicians is that they rarely say anything of value and they take far too long to say it. I'm going to try and change that by hopefully saying something of value, and I'm going to be short. Every day as a Minister for Health, I dealt with the limitations of care that I could provide because of insufficient money to pay for everything that every doctor wanted to provide and that every patient thought they needed. So a large part of what I'm going to say will focus on the specifics of payment for these services, because it's my complete contention that unless one gets the payment mechanism right, the high-value healthcare that we're talking about actually can't be delivered. And it may be pedestrian and boring in such an erudite conference to talk about the nastiness of money, but in my direct experience of running health systems is that if you don't pay for something, it doesn't get done. So in talking about Qatar and its experiences, I want to use Qatar as an avatar for every other place in the world that should be looking to do these sorts of things. So where is Qatar on the accountable care spectrum as we sit here in WISH 2018? And I want to read from the report from the Accountable Care Forum in 2016. And it says, amongst lessons learned from the pilot and, importantly, next steps, it says the pilot demonstrates how a health system can begin implementing accountable care by reorganising care delivery before addressing payment reform, which could be a protracted and bureaucratic process. In saying that, of course, this report is 100% wrong, because payment reform is always a protracted and bureaucratic process. But that's what Qatar's done. Qatar's actually implemented accountable care. It's reorganised some of its care, but it hasn't yet addressed payment reform. The report goes on to say, which is an avatar for everyone in the room, sustainability of the pilot will depend upon payment reform. And we all know that there are billions of very successful, well-meaning pilot programs that have been run throughout the world, which look terrific, which start getting and delivering good results and run out of money and they falter. So unless you get the payment mechanisms right, the pilots will stop. And the report, the last thing I read from 2 years ago, the stakeholder group could recommend payment reform options to the government, such as per member per month capitated payment, which Mark mentioned before. I happen to be a huge fan of that, or a predetermined amount that the provider receives each month for each person whose health outcomes for whom they are responsible. So that's where we were looking then. So as we've heard, the Al Wakra Diabetes Project has been a success. Fabulous results, actually demonstrable, and it's now expanding into smart health checks. I would contend, however, that is, if you actually analyse what accountable care is, according to Mark's definition, it's more an integrated care system rather than an accountable care, strictly speaking. So what has progressed positively in Qatar towards accountable or high-value care? And again, I reiterate, Qatar is an avatar for whichever country in which you live. Well, all the lessons are non-negotiable in every health system. Qatar has developed a strong, focused policy direction called NHS2, the National Health Strategy version 2. It's fantastic the way the health system has bought into it, and what I adore about it is that it has specific goals, targets, KPIs, timeframes, and reporting mechanisms. And there is nothing like the fact that we have to report to someone on how we're moving a progress forward for actually getting it done. And integrated care is one of the main policies, directions in NHS2. We've developed an IT hub, or are developing it, which is one overall system into which all the elements of Qatar will be able to access with appropriate authorities. We've got improved licensing for the practitioners, and fascinatingly, we're starting to get projects that are coming from the bottom up. The one that I will talk about is Better Together, which I think is astoundingly brilliant, but it's a bottom-up initiative, and it presages integrated care meeting in a pincer movement with the ones up above, the movement coming from up above. What hasn't progressed as rapidly is actually accountable care, or the payment mechanisms. Not surprisingly, accountable care means that people are accountable for the care that they provide. And I contend, as a former minister always constrained for money, that should include financial accountability. Most practitioners shudder when people say that. But in the US, Mark being the prime example or prime leader of that, there are many cases where the best outcomes for the patients, all of those things that Mark mentioned, have been delivered where money has flowed from one organisation or one person providing a particular model of care into the more integrated model where the best care is being provided and it gets more money. Thus far, that hasn't happened in Qatar. Now, of course, in money reallocation, some people may lose, but the best providers will benefit. And who doesn't want the money that they have been paid for their healthcare being spent with the best providers? I certainly do. In Qatar, the private sector doctors are paid for as fee for service, and I'll talk more about that in a minute, but the public sector isn't. However, if the doctors, just to quote some examples, if the doctors get well paid for doing night clinics, what is their incentive to discharge patients from the hospitals to the PHCC? A proper capitated incentive payment system would change this. And I'm thrilled to tell you that doctors around the world are mainly capitalists. I think that is terrific, because as soon as we acknowledge that, it gives us a means to make them or to ask them or to provide them or to give them incentives to do what we want them to do, rather than what they want to do without any other state of mind coming into it. My simple theory around everything is that if I want a bunch of bees to go into one corner of the room, I will put the honey in that corner of the room. If I want all children to be immunised against deadly children's diseases, I will put the money into children's immunisation. And if we want doctors, nurses and hospitals to be accountable for the care they provide, we should put the money in that corner of the room. So, in order for Qatar, and I reiterate for about the 15th time, it is just an avatar for your country, to enable Qatar to seize the advantages of accountable care, to provide the highest value care, and to make decisive and meaningful change, we need to be bold, and we need to redesign the funding model. Fee for service provides fee for volume, not fee for value. If you actually look at the name, fee for service, it's extraordinarily efficient. You pay a fee and you get a service. Where does it say a fee for the best service? Or perhaps even a fee for the most appropriate service? It doesn't. It says you do any old service and lo and behold, you get paid for it. Not good enough in the 21st century. And sadly, health insurance doesn't always focus on the best allocation of the money. In Qatar, we've had a checkered history with health insurance, and we are in the throes, and have been for quite some time, of developing a new system. Any new health system from around the world today would have, I would contend, starting from a blank page, 8 non-negotiables. Universal coverage, value-based outcome payments, accountable care, empowered patients, comprehensive community outreach, GP or primary care focus, and illness prevention model and state-of-the-art IT. Health insurance on a fee-for-service model pays for one of those 8 criteria. So we need in Qatar and around the world to change the system, and that means we need dramatically to focus on change management. I conclude by going back to the very beginning of this symposium, when Professor the Lord Darcy of Denham, in his fantastic opening speech, by the way, I've been in Qatar for 2 years, it's one of the first times I've heard people acknowledge and demand of us to address the political situation. It was a wonderful speech. So Ara said two things. One, WISH provides a unique forum to foster new ideas and innovation. We should seize that unique opportunity. And he also said it's very difficult to get a good idea to spread throughout the health system. Well, 2/3 of you identified that you come from Qatar. The reason that you've come to this session is because you want Qatar to provide better value, high value, and you want the providers to be accountable for the care. Let's all work together to change the funding model and deliver accountable care in Qatar. Thank you.
Michael, thanks for your comments. I think you were up there with Lord Darcy in terms of willing to be out there, out with some bold statements for discussion. Michael emphasized that the experience here he didn't think was unique in terms of having a system that has very important goals in mind but may not have the exact organizational structure capabilities to support the innovations in care that are really needed to get there. And I would agree with you that financing is important. It does seem like on the primary care side here you've been able to have some additional resources to expand out what you're doing in primary care, which has made a big difference. But you're talking about some more fundamental transformational change to align specialized care even more deeply with the goals and embedding and even more person-focused approaches to care. And I would say that the most health systems, including the U.S., are still a ways away from that. We have in the U.S. many hospitals that are seeking to become more population-oriented, that are looking to change away from a fee-for-service or DRG per admission model in order to get there, so they can do things like intervene earlier with cancer patients who are having complications, to head off the need for them to be admitted to the hospital with fever, to develop better patient care plans so they're doing the right treatments on the right patients, for the patients with joint disease to find more effective physical therapy, patient-centered programs that can head off the need for joint replacement surgery. And in less developed countries too, and those that are emerging into more advanced systems, also a lot of interest in designing new care systems. I had the privilege of going to China recently and meeting with some hospital and healthcare leaders there who would like to, as they expand spending on healthcare, not to replicate a sort of a DRG-based hospital-focused system, but instead have one that benefits from some of the innovations in internet-based communication, WeChat, other personalized service platforms that could provide a basis for real-time, ongoing primary care support for patients in a very different way than traditional healthcare has been delivered. And then working with efficient systems like Narayana has developed for providing those specialized services. But it is not easy to get from here to there, and would emphasize that while the money is important, also the political leadership around a vision for patient-centered care and tracking first and foremost measures like you're doing around population health and well-being is very important, about supporting the incremental changes in care organization, training, and the like. But we're seeing more examples of this happening. And I know many of you here are from Qatar, many of you here are from other places as well. I would like to open up this discussion to those of you who are in the audience and may have had some experience or another, maybe like Michael's, with the shift towards value-based care and supporting truly well-coordinated, prevention-oriented care. we'd like to hear about your experiences or comments, questions, critiques on what you've heard so far. Please go ahead. We got microphones going around too.
Oh, thanks. Hi, I'm Larry Friedman. I'm the Associate Dean for Clinical Affairs at the University of California, San Diego, and Professor of Medicine. This is really incredibly good. So I congratulate you and thank you for your presentation. I really have a question, and we're, by the way, are sort of in the middle of where a lot of big academic medical centers are in the U.S. of doing this transition from volume to value. And it's easier to do it all at once rather than be in the middle. But my specific question around the no-show rate, have you thought about doing home visits and shifting care to home rather than clinics? Because clinics, first of all, transportation is a problem, and fundamentally, people would rather get their care at home. We, for instance, send vans out to people's houses who don't come in to get their blood taken. And we're transitioning to many, many, many more home-based visits, which I know have been very popular in Britain.
You're paying for that based on moving away from your old fee-for-service contracts, yeah.
Pay for because we're assuming large risks for large populations of patients.
Yeah, thank you for the questions. Actually, you are exactly right. We think about it, and I think we have to probably, it is the answers, because with such a no-show high rate and such a simple, innovative way for population health, we have to think of home health, and we are building our capacity to just do it in one day. Okay.
Great question. Please go ahead, and then we have a couple more questions on this side of the room next.
Okay, thank you for giving me the chance. I appreciate this topic. I have a simple question. How can we convince the new physician specialist or new bedside nurse that he should be engaged in the accountable care? Thank you.
Great. Do you want to? Okay, and it can't just be the money's important. But it's not just about the money.
No, I'm particularly optimistic about the younger professionals, and I'm talking about the ones in, say, medical school. When I went through medical school, we had one session in 6 years on billing and payments. That was all. Now, I think the younger student can be inculcated in the values of accountable care, of integrated care, and so on. And in fact, many of them are much further advanced than some of their lecturers, I have found. But I think this should be part of each of the care learning programs on the basis that it provides better outcomes. And I don't know of a single doctor, nurse, or whatever who goes into their training wanting to do worse for the patients. They all want to do better. And if you can demonstrate to them at a young age that in fact integrated care and being in the community and taking care into their homes, as happens a lot in South America, as we all know, if that provides better care, the younger will grasp it. So I'm quite optimistic. It's the next 25 years before they start calling the shots that's the problem.
Yeah, we've at Duke started a specialized training program, especially for healthcare leaders, not just physicians, nurses, others who are involved in care delivery around these approaches to care. Very strong interest from students. It involves an emphasis on things like team-based care and being able to describe longitudinal pathways and reorganize the money. But I would say for people who are in practice in these systems, one of the, and I'd like to ask you about this, Dr. Samia, one of the metrics that many organizations that are implementing accountable care use is a measure of the satisfaction of the providers with the care that they're delivering. In the U.S. And in other countries, there's been a lot of frustration with fee-for-service, only being paid for certain services, not really being able to spend as much time as you'd like with a patient, recognizing that there might be a different approach to care that would be better for them. And then in some of these models where you do have a team to rely on, others, you know that the patient's getting some additional help. You can focus more on the things that you really want to do, and fewer billing hassles, so patient satisfaction may be high, but but provider satisfaction may be higher too. It's another important metric perhaps to track.
Okay. I think probably how can we teach it's just about teaching all workforce training, not only physicians, about how cost effective is it, and it just starting early in the training, that it's not a matter of care. So we have to even we have to raise awareness about that self-care for our patient, that how can we emphasize and empower and engage our patients, doing some sort of taking responsibility and shared accountability for their own cares, because just as most of these disease and are chronic and debilitating and cause economic burdens, so why not to start early and teach our patients and empower them to do some lifestyle modifications. Most of the disease and chronic disease are modifiable if we start early, so why not to just enhance our self-care and taking care of themselves. And it's a shared responsibility actually in the community, between patient and physicians and the leaders and everybody. Thank you.
May I add to that? I saw a fascinating survey some years ago from Kaiser Permanente, which has salaried doctors, which immediately takes the fee-for-service element out of their payment, and in fact their satisfaction as a provider was much greater than people who were looking at fee-for-service, because they were there just providing healthcare.
Yeah, so tracking provider satisfaction is a good metric in these reforms. And over here, and then up front.
Hi, Terry
Go ahead.
Simons from Victorian State Government in Australia. I just wanted to comment on the issues around where funding reform fits in the order of implementation. Our experience is much like you've commented. We've spent the last 2 years relaxing our DRG-based payment models for patients with chronic disease who are frequently admitted to hospital, and it's taken a long time to get the risk stratification formulas right and play with this stuff. And so we don't think it's it can be the first thing that is done because it takes so long. We're starting work now on stroke. We think that the first task for stroke is for patients and clinicians to be clear on the value proposition here in stroke. It's a little bit interesting for stroke because there's been some game-changing innovations in technology around stroke, which is relevant for maybe 20% of patients with stroke, but for the largest group of stroke patients, mechanical clot retrieval and immediate thrombolysis are not relevant. So it's about what access to rehab and other treatment is provided to reduce long-term disability. We think getting clear on that and getting data to support that value proposition is probably the first step with patients and clinicians, and funding reform will follow. But there is one example where I think funding reform is absolutely the first, and that is where the current payment model is a disincentive or a barrier to local innovation. So we are thinking about large-scale demonstration projects, and funding reform is going to take some time, but there's lots of little innovations that people in the system would like to make, but the current funding model is a barrier. And I think for those, as government, our job is to provide very quick waivers from the current funding system and let them get on with it. And one example I'll share is around bariatric surgery, where our state bariatric surgery provider says, look, we have a good model for conservative management and pre-workup that takes some time before people are candidates for surgery, but you pay us for the surgery. You don't pay us for all the group sessions and education and work that we do with patients to decide whether they're candidates. We'd like to bundle this stuff together. And our team in the department, kind of says, well, we haven't got all the data around this, we haven't done all the pre-work, it's going to take a year of work to kind of think this through. Who cares? Give them a waiver, roll the whole thing in together, let them get away with it. We'll work out the data as we go to properly evaluate it. They have a good registry, they're starting to collect patient-reported outcome data. We'll learn a lot from these people as they go. It's small scale, so I think we're probably heading towards a two-tiered system where for large-scale demonstration projects, funding reform may not be the first, it's going to follow, it's going to take time, but we should be really quick and ready, I think, to provide waivers and relax funding models where they are barriers to reform for local innovation. So that's my contribution on that issue.
Terry, thanks for the experience. I mean, Michael, maybe after you're finished with reform in Qatar, you can go back to Australia and help Terry out.
Not sure the Victorians would want it.
But the basic idea, Terry, that I think you're describing of if you can't do it all the way, at least starting to move some of the regulatory barriers and payment barriers that are focused on delivery of traditional services in the direction of better care for patients, and doing it with building an infrastructure, supporting the organizational change, and tracking performance seems like the right way to go. To your comment earlier, boy, it's hard work, but so is changing payment. So is really changing healthcare. So I hope you'll continue in that direction. I think we can maybe compare notes to some other systems around the world that are making those similar kinds of incremental changes towards more shared decision making and towards more steps to prevent or avoid costly procedures and complications. Any other comments on? Thank you. So up here.
Hi, I'm Dr. Duriya Al-Qahtani. I'm Director for Integrated Services and Continuity of Care at Primary Healthcare. I just want to add that at PHCC we are exploring how to implement the model of case management. So by implementing this model, we are identifying the needs and demands of home care patients. So whether it's for screening, for vaccination, even for appointment at for referral to secondary care. And by implementing this role model, we are trying to focus on this patient and what's the need that can be provided at home and what are the needs that should be provided at primary healthcare facility or secondary care facility. And all the logistics around it, like transportation, booking the appointment for the patient and reminding the patient for his appointment, delivering the health education at home for the patient and for the family or the caregivers. So this is one thing. The other thing is I just want to share my point of view regarding the payment, where the payment should be focused. Reflecting on the current situation, we can see in Qatar that there is a lot of investment in providing care to patients who are, for screening, for managing the chronic conditions. But at the same time, there is a lot of money invested or spent or wasted on unhealthy lifestyle. For younger children, for the adults, and for others. If you go through the malls in Qatar, you can see all type of processed food, just decorated and affordable to children, affordable to all who can eat it and get sick, and then enter the whole system again, the pathway to be treated and to be screening, treated, and rehabilitated. And you can see that. Even the food delivery is everywhere. Unhealthy food delivery is everywhere. If you're a child, you can just contact Talabat or whoever, and with 50 riyals, you can get all the food you want, or you can bypass even the parental control in this issue.
Well, I certainly don't have any solution for bypassing parental control. I wish I had 30 years ago. The issue in Qatar is two things that I would say about your observations. One, we are dipping our toes in the water of looking at sugar tax. That's variably successful around the world, but that would be certainly a way of indicating healthier lifestyle, healthier eating. I personally think that the anti-smoking legislation in Qatar should be enacted more strongly, but that's my personal opinion. But of course, I've just come, and I know others of you have as well, from the session on health in all policies. And I think that's really where Qatar needs to put a lot of energy, and it is part of the National Health Strategy version 2, because there are so many other things. One of the things I note as a newcomer to Qatar, I happen to like walking, and yet I can't walk in Qatar because most of the roads don't have any sidewalks. Now, that's a responsibility of the Minister for Transport, and there shouldn't be a highway or a road built without a sidewalk. So there are lots of things that could be done to improve, and we're getting there.
Yeah, it is helpful to have the focus that you're describing on keeping people healthy. You're building it into the health policies and the healthcare system. But as Michael said, this is a set of policies that needs to be reinforced in other sectors. In the United States, where we're spending increasingly all of our money on health care, a number of organizations that have moved in this direction of accountable care and focusing on population health are now setting up programs for food prescriptions for their patients with diabetes and risk factors that deliver to their home instead of the pizza, fresh foods and nutritional guidance and home-based support for getting there, and that can, in a good model, be more practical. And many countries, England, others, are trying to do more to integrate social care with medical care around this focus on population health. So I think we're about out of time. I'm going to go to Lee. Please go ahead, and then.
I'm the CEO of acute hospital in Singapore, as well as overseeing population health, the regional health service for population around 2 million. I think this is a very interesting topic, which in Singapore we are also learning and trying to see how to best manage it. I think, but there were a few key lessons that we have learned. One of which is the importance of the language. We have tried to move away from just calling patients to calling them residents or persons, because as long as we consider them as patients, these are people who come into our healthcare system, but increasingly we see the need to move upstream.
Yes.
And because we know that a good start is important for, in the war on diabetes, is, the children who are obese at a very young age, the likelihood of them being obese later in life is high. So we have to move upstream, give them a good start, give them a good peer influence, as well as a good program as they go along. The other thing that we need to do is also to bridge the, as Mark has said, the social and the medical divide. Because as one of my colleagues keeps saying, healthcare is medical, but health is social. And our people live out in the community, and that's where their lives are lived out. And we need to then manage them and to understand them in their natural context, rather than in a very artificial healthcare environment. So the further we are from the community, the primary care is a bit closer, but in the hospital it's a very artificial environment, and their habits and behaviors are very different. And I think the final one is also to then also need to redefine our goals, that it is not just about the medical related goals, reduction in readmissions, but also to look at functional abilities, because those are the things that actually matter to the people, and which is why, come back to my earlier point, we need to redefine it from patients to persons.
To
Thanks.
people and their functions. I think, so I think you're agreement with Leisha on her statement. And speaking of redefinitions, I think you introduced yourself as the leader of a major acute hospital system in Singapore. You may need to redefine your role, since pretty soon, hopefully, it's not just going to be about the mainly about the hospital care. I'd like to thank Dr. Soumya and Dr. Armitage for being with us today, and thank all of you for your comments. This is a journey, but very pleased to see the interest in reforming care to focus on people and succeeding in doing it, even though it's hard. We'll continue to offer support in this direction through WISH, and encourage those of you who are interested to also reach out to us at the Duke Margolis Center for Health Policy on these issues. Thank you all very much for joining us today.